Really, hormones, is something that biologically we all have. Testosterone is in every man, woman, and child. And unfortunately, with time, it deteriorates. And if you don't pick up on that, it's very symptomatic, and it can be very detrimental in the well-being of every person. I tell you, the number one reported symptom, fatigue. I am tired. I am fatigued. I don't know why. I'm only 35, and I'm seeing younger and younger people have these symptoms. Not only, you think about a lot of these symptoms are libido driven, erectile dysfunction, fatigue, body aches, sleep disturbance, and you think of older age. You think of, 50s and 60s and post midlife crises, but really I'm seeing it younger and younger and younger. So the fatigue is the big thing. Benefits. One you mentioned, energy, huge, well-being, mental stability, sex drive, sleep recovery. Sleeping, it's a huge for sleep and recovery, which is where our body gets its rejuvenation from. Weight loss. It's a metabolic compound, so if it's deficient, it's so much harder to lose weight, and that's where I see a lot of people get frustrated. They exercise and they diet and they really work hard for a couple months, and they get so depleted they put themselves down because they're not getting the results they desire, and usually it can be linked to a hormone deficiency. So testosterone is not only one of the ones that helps develop a natural circadian rhythm and really good quality of sleep, but it can also be depressed with certain sleep disorders, in particular obstructive sleep apnea. So if you have undiagnosed sleep apnea, it can actually facilitate low testosterone, and then you kind of get stuck in this cycle where with obstructive sleep apnea is usually related to weight gain, and unfortunately, those two things suppress testosterone even further. So diagnosis is, I say tricky, but not. What you want to try to do is initially you want to look for other medical diagnoses, just like you is going to look for differentials. Why is this patient symptomatic? Why are they having the fatigue? Why are they having the low sex drive? Why are they having problems with weight gain or loss, sleep recovery, all these things? So we're always trying to answer the question, why? So when I draw labs, I'm always thinking about that. I'm looking at, the complete blood count, looking for any anemias. I'm looking for their metabolic panel, looking for any electrolyte imbalances, liver disease, kidney disease, thyroid disorders that could be playing a role in these symptoms, which is very common. So typical, we see a testosterone deficiency. Then we start kind of backtracking. Why does this person have a testosterone deficiency? Is it because they are not getting the stimulating hormone to the testicles or the ovaries or the adrenal gland that produces the testosterone? Or is it just a biological deterioration, which happens? We're a machine, and unfortunately machines tend to deteriorate.
So the testes over time produce less testosterone?
Correct, yes sir. So you have two forms. You have a primary hypogonadism and a secondary hypogonadism. So is it the testicles that are not being stimulated to produce the testosterone, or are the stimulating hormones sufficient and the testicles are not able to kind of keep up per se? The testosterone level does fluctuate. It's highest in the morning, around 6 a.m. in the morning biologically, and later in the evening, around 12 hours later, it's at its lowest point. So I like to see both. I like to see early morning and I like to see late afternoon. And that way I can differentiate where the patient is having such a drastic trending change, which happens usually up anywhere between 30 and 40%. You can have a swing between the early morning testosterone and late evening testosterone. So I feel like a lot of times if someone's not savvy enough or just not in tuned enough to realize that there are drastic changes in hormone levels, that a lot of people are being either misdiagnosed or overlooked for a possible deficiency when perhaps they were just tested at the wrong time. You know, we're taught, we're instructed to, you know, go through the guidelines, but, you know, I really put a bigger hold on the clinical aspect and the clinical symptomology for the patient. So, you know, just per se, you know, just say a 45-year-old guy comes in and he is fatigued and he can't lose weight and he doesn't have that desire at home, the intimacy level's down, he's got erectile dysfunction, and I rule out every other problem and his testosterone's 400, so what? The guy doesn't feel good. The guy is having so many symptoms that I could directly relate it to his testosterone. The easiest thing is optimizing. Who wants to be at 400 when I can be at 800 and it's still considered normal, or 900 or 1,000, where you can have resolution of these symptoms and just overall better quality of life. Multiple modalities. I in particular like the injections. You know, it's very quick acting, they're easy to manipulate. It is a needle. You got both. You got subcutaneous and intramuscular. I tend to recommend intramuscular for men. You know, men have more muscle density, so it's just kind of the normal, I would say, method of insertion is intramuscular. For women, I do subcutaneous injection for women, whether it be the tricep, whether it be the abdomen, whether it be the thigh, whether it be the butt. Self-injection, yes sir. Everything is done at home. So a lot of times when I initiate initial testosterone replacement therapy, I usually have an in-service in the clinic where, you know, we'll go through the steps on how to draw up the medication, how to properly inject, and the patient does it at home. A lot of people don't like to do self-injection, but I have had nobody complain once they get optimized, because again, it's a night and day difference. You know, there's transdermal, which are the lotions, the creams, these sort of things. I don't feel that they're the best. Most of them are ineffective. The other one, oral. Some of the oral medications, not testosterone. Oral testosterone is no longer approved and prescribed, but oral estrogens and progesterones for the women. And then you got the new thing, is the new craze is the pellets. The pellets, you know, have been a newer kind of onset to the stage. I don't like them. Because again, you take away that manipulation. You know, once those pellets are injected, inserted into usually the buttock, you're in for the roller coaster ride. You got to buckle in, because you don't know whether or not it's going to be great, whether it's going to be terrible. So when I start initiating TRT with men, anywhere between 3 to 4 weeks is where they really start kind of seeing these changes. Oh man, I got a little bit more energy, or when I get off work, I don't sit on the couch. I want to get out and still do things. I want to go rake. I want to go play with the kids. Women usually quicker, believe it or not. I start women on testosterone injection therapy, and their energy levels skyrocket. Their sex drive comes back. You know, they're chasing their men around the house. The men are happy because they're feeling better. So it's a mutual thing. You can't only treat half of the solution. So the costs, you know, are you can look up 10 different men's health clinics and they're all going to be different. Mine, I feel like I made it the most affordable because, again, I don't want to deter people from being able to seek out this type of treatment. A lot of the insurances don't cover initial consultation fees and office visit fees because it's kind of in that gray zone of fertility and hormones. And I think, again, the insurance are still in prehistoric age when it comes to that. So it is cash pay, very affordable though. Consultations, $100. Follow-up visits, $50, and I try not to make those very often. You know, a lot of the stuff that I do is via text messaging and email, so I try to limit the costs. Insurance, all the labs and blood draws can be filed through the insurance, so that's not out of pocket. Some of the insurances will cover TRT management, and what I'm referring to is the testosterone injections themselves. But even if they're not covered, testosterone is very inexpensive, roughly $100, anywhere between $100 and $125 for 3 months worth of supplies. So really what it comes down to, you look in between $40 and $50 a month. Which I feel like is very affordable for all aspects of life. It can cause thickening of the blood, erythrocytosis, and with high blood counts, you can have high blood pressure. You know, there is no sense of aggressiveness with testosterone replacement. Because this is a natural biologic hormone, there are not any direct interactions with any medicine. So the bottom line comes down to this. This is something that is happening biologically. I think it has 10 times as many benefits as it does risk factors. One day, I think everybody over 40 years of age should be on hormone replacement therapy because it's optimizing health. And, it's just a good positive feedback when I hear that, men are getting home and they still have the activity level or the energy to still go out and play with the kids and have family time. So it is really kind of trying to restore that overall well-being picture at home and as well, just that good quality family time.